But very timely, I'm going to talk about the AstraZeneca and J&J vaccines. I like to try to go over the science and trials as much as possible, because then people can really understand and make decisions for themselves regarding these vaccines. I'd like to begin with a land acknowledgement. I live in Toronto and work in Toronto, and it's the traditional territory of the Wendat, Anishinaabeg, and Haudenosaunee. And Toronto is covered by Treaty 13 with Mississaugas of the Credit First Nation. I identify as a settler, and I acknowledge the importance of treaties and the importance of the Truth and Reconciliation Commission of Canada. And if you haven't read it, I highly recommend reading it. Here are my disclosures. And in terms of financial support, and in terms of mitigating potential bias, what I'll be presenting is peer reviewed. Okay, so I'm going to review how the COVID-19 non-replicating adenovirus viral vector vaccines work. So that means the AstraZeneca and J&J vaccines. I'm going to review the AstraZeneca and J&J COVID vaccine clinical trials. And then we're going to discuss the pressing questions, the adverse events like vaccine-induced thrombosis and thrombocytopenia, and variants of concern. Let's get started. So I've presented variations of this slide before, but let's go over it. So to make these vaccines, what is done is the COVID-19 spike protein is taken, and the DNA that encodes for the spike protein is inserted into an inactivated, non-replicating chimpanzee adenovirus. Okay, and the adenovirus is a DNA virus. And then, so what it allows is DNA of an important protein for a vaccine to be inserted. And the fact that it's DNA allows the product to be more stable. Single-stranded RNA is more unstable, so it's harder to contain, and so that's why the messenger RNA vaccines require -70 degrees or -20 degrees for storage. But the adenovirus, being DNA, can be kept at refrigerator temperature or even potentially room temperature. And so then the adenoviruses are injected into the person, and then the adenovirus enters into the cell, and then spike proteins are made, and the immune response happens with antibodies being formed to the spike protein. This is not the first adenovirus vaccine. For a long time, the animal rabies vaccine has been an adenovirus vaccine, and then more recently, the Ebola virus vaccine that has been highly effective and is being used is an adenovirus vaccine. Right now, we have two inactivated viral vector adenovirus vaccines approved, the AstraZeneca vaccine and the Johnson & Johnson vaccine, and they actually use different adenoviruses for each of these vaccines. Okay, let's look at the clinical trials. I have presented this one before. This is the AstraZeneca vaccine clinical trial that was submitted for Health Canada and FDA approval. It was published in the Lancet December 8th, 2020, and it's still ongoing. They actually ran 3 studies, one in the UK, one in Brazil, and one in South Africa. One of the studies compared to meningococcal vaccine as the control group, and then the 2 other vaccines were against placebo saline. And in all of these trials, the vaccine was given at day 1 and then at day 28. And again, because it's DNA, it's more stable, it can be kept in the fridge. And the primary endpoint was confirmed SARS-CoV-2 by NP swab, but only in symptomatic patients 14 days after the second dose. You might hear my dog snoring. Sorry about that. 23,848 participants were randomized, and this study reported on the interim analysis of 11,636. And if you remember when I presented this, I think it was in January, I explained that there was a computer error that happened, and 2,800 participants actually got a half dose for their first dose. And then at their second dose at day 28, they got the standard dose. Once they figured out the computer error, they stopped it and continued with the 2 standard doses for everybody. But AstraZeneca, as well as regulators, decided to continue the study with this lower dose arm. And everyone was surprised because in the 2 standard dosed arms, the efficacy was 62.1%, but in the low dose standard arm, it was 90%. And I'm going to go over a little bit, why that might be in a few slides. But it's important to note that in the 10 severe cases were all in the placebo group and none in the vaccine group. Here are the common side effects of the AstraZeneca vaccine. So injection site reaction, fatigue, headache is more common than with the messenger RNA vaccines. And in fact, all the side effects are a little bit more than the messenger RNA vaccines. This is a presentation or analysis of just the US study. And so in the interim analysis of those enrolled in the US study, the overall efficacy was 79%. And for those over the age of 65, it was 80%, and it was 100% effective against severe or critical disease and hospitalization. And this analysis was done with 32,449 participants. And I think this is one of the things that has been hard, is that with these vaccines, there's different reported efficacy rates as every trial finishes and comes out. This is the one that this analysis is the one that I think is most important in terms of the AstraZeneca vaccine. In the original study that I presented, they did some exploratory analysis, and they found not everybody in studies gets the vaccine at the second dose at day 28, or even in the Pfizer studies, not everyone got the second dose at day 21. So in this study, many patients got the dose late, and in fact here, here the efficacy was 81.3% after the 2-dose regimen, when the second dose was given 12 weeks or longer after the first dose, compared to 55.1% when given less than 6 weeks. I think this has to do with something that's happening that was revealed with the low dose standard dose regimen, whereby if you give the 2 standard doses too close together, and this happens with some other vaccines, for example, the Pneumovax vaccine, if you give them too close together, the second dose dampens the immune response from the first one. The other aspect that I think is important about this study that it showed is that antibody levels persisted, and there was efficacy at 76% from day 22 to day 90. Okay, this is trial results which you may not have seen yet. It's the Johnson & Johnson vaccine trial results. This vaccine is given as a single dose, and they enrolled 44,325 participants. And this interim analysis is up on about 39,000. So the overall efficacy of the J&J vaccine was 66% for preventing moderate to severe disease, 85% for preventing more serious outcomes, and 100% effective at preventing COVID hospitalizations and deaths. Their primary endpoint was COVID in symptomatic patients after 28 days, but they also reported it after 14 days. And I think this this slide presents it a little bit better and clearer. So in terms of the primary outcome, the efficacy of this virus in the US was 72% for moderate and severe disease, and 66% and 57% in Latin America and South Africa, where both of these areas had important variants. So the efficacy was reduced, likely related to these new variants, but still efficacious. And again, 85% at preventing severe disease and 100% at preventing death and severe disease past 49 days. Okay, pressing issues. I think what you want to hear about and what people are really interested in is this serious adverse event, VITT, vaccine-induced thrombosis and thrombocytopenia. So in lay terms, it's being called as clots, but it's not just clots. People who get this also get low platelet count. So those are the cells in the blood that cause clotting. So people present actually with clots and bleeding, or clots or bleeding. It was flagged by the EMA, the European Medical Agency, after 20 million people in the UK and the EU had been given vaccines, and there were 7 cases of blood clots and 18 cases of cerebral vascular sinus thrombosis. So we remember how in the EU they had halted giving the vaccine to characterize this a little bit more. So yes, it is a real issue, but it is rare. It happens 98% of the time in people under the age of 55 and 90% of the time in people less than 40 years of age. But we're understanding it and characterizing it much better. I don't know if Mark has seen any cases yet when he's been on service, but people present with symptoms up to 20 days after the vaccine. And if they do, they should go to hospital. And so those symptoms are severe worsening headache or blurred vision, because that's because of the cerebral venous sinus thrombosis. That's where it's located. Breathlessness from a pulmonary embolus, swelling or coldness in a leg from a clot in the leg, pain in the chest or in the stomach. There's been some stomach vein clots, persistent bleeding, or multiple small bruises, and people should go to the hospital right away. And so, yes, a lot of people are scared about VITT and blood clots, but we have to put this into perspective in terms of the risk of blood clots that we potentially take every day. So in terms of the risk of clots or VITT from the AstraZeneca vaccine, it's being said to be 4 in 1 million. More detailed rates are coming out based on age. So you might have seen those in the news lately in terms of, for example, this is 1 per 250,000, but if you're younger, it could be 1 in 50,000 or 1 in 100,000. So still low and rare. The risk of clots from birth control pill is 900,000 in a million. The average Canadian has a risk of clot of 1,290 in a million. And one thing that experts are saying is that the risk of clots from the AstraZeneca vaccine is much less than the risk of clots if someone's hospitalized with COVID itself. COVID causes there's a thrombosis phenomenon with it, and 14.7% of people who actually acquire COVID gets clots. And again, to put this into perspective, something that we wish we were doing, which was getting on a plane and flying, but the risk of blood clot from flying is 1,000 in a million. Therefore, experts support that individuals greater than the age of 30 get the AstraZeneca vaccine. And this is even if a person has a known clotting disorder, because the mechanism is different. And I'm going to go through that. The mechanism is like an autoimmune mechanism, and it's similar to the mechanism that happens when people develop anti-heparin antibodies. So right now the vaccine is being said to not be given to people who have a history of an autoimmune disorder to heparin, so anti-heparin antibodies, or potentially to platelets. We maybe can give it to them, but experts are saying not to give it in these cases, and these are very, very rare, and people would know if they have them. Where do we get that cutoff of 30 and plus? Some of you may have seen these slides already. They were put out by Cambridge, and the European Medical Agency has been using them to advocate for the distribution of the AstraZeneca vaccine. They did an analysis showing the potential risk of someone ending up in the ICU due to COVID per 100,000 compared to getting a blood clot from the AstraZeneca vaccine per 100,000. And this risk depends on the incident rate of COVID in your area, or prevalence of COVID in your area. If you live in a low exposure area, you can see, let's go to the group that is approved now, so 40 to 49. The chance for this age group of getting severe COVID and ending up in the ICU is 5.7 per 100,000, but to get a clot is 0.5 per 100,000. And then when you go to the group that's 30 to 39, it's 2.7 versus 0.8. But when you go below 30, the numbers start to become closer. If you move to an area that has medium prevalence of COVID, you can see the COVID risk and incident numbers go higher. So then even at 20 to 29, separation in terms of risk starts to happen. And if you live in a high exposure and highly prevalent area, you can see even a greater difference. And then at that point, it might make sense to give it to people who are 18 and over. What about the risk of VITT with the JNJ vaccine? So that was just published a week ago in JAMA. And this is the name of the vaccine, AD26-CoV2S. And so the authors reported that by April 12th, there were 6 cases of cerebral venous sinus thrombosis out of 7 million doses given. Then there were 6 more cases reported by April 21st, all with this CVST. So they reported on the 12 cases. All were in women from the ages of 18 to less than 60. Symptoms developed between 6 and 15 days after getting the vaccine. 11 of the 12 presented with a headache. 7 had intracranial hemorrhage in addition to the thrombosis. And I think we're actually probably getting better at diagnosing this phenomenon and treating it. Earlier in the year, when these cases were happening in Europe, unfortunately, all the cases died. But now people are going to hospital, and you can see out of the 12, only 3 died. 3 were still in the ICU, 2 hospitalized, and 4 discharged. In the paper, they also commented on additional cases after April 21st, and I just wanted to comment on that because one of them was in a man younger than the age of 40, and then the other was in a woman aged between 40 and 59. So I just wanted to comment that this serious adverse events also does happen in men. So it has to be looked for in men also. I think the important thing is we know the mechanism now, and this was nicely published in 2 papers in the New England Journal of Medicine, one by a German group and one by a Norwegian group. And in all of the patients that were included in these case series from Germany and Norway, they had high levels of antibodies to platelet factor 4, which is what is also implicated in heparin-induced antibody syndrome. And we're starting to better understand that it might be actually a protein that's in the adenovirus vector that triggers this. And now that we know the mechanism, and Mark can maybe comment, we know the treatment, so it is anticoagulation, but it's with an anticoagulation with an anticoagulant other than heparin. Okay, variants of concern. I know we have people from all over the country, but I have the reports from Ontario here. Variants of concerns are here. The most important one in Canada is the B117. That's the one from the UK. And this one is likely to take over fully in Canada as the main variant because it's so transmissible. The most transmissible variant is the one that always takes over. You can see in the blue here in Ontario, as of a week ago, the blue is all the B117 variants, and we're really ending up with the majority of the Ontario cases having B117. And just in case you didn't believe me, I put the raw numbers here so you could see that really there's less B1351, which is from South Africa. We have had outbreaks of the P1 variant from Brazil here and here in pockets. And of course, there were the important outbreaks in BC with the P1 variant. In terms of the vaccines, the Pfizer, Moderna, AstraZeneca, and JNJ, so all the vaccines are effective against the UK variant. So that's the B117 variant that we mostly have now. And the Pfizer, Moderna, J&J are effective against the South African variant, but the AstraZeneca vaccine is not effective against the South African variant. You might ask, well, what about P1, or what about the Indian variant now, B1617? From looking at the mutations, those variants are very similar to the South African variant. So I would say the vaccine efficacy would be similar to the South African variant, and might be contributing to what's happening in India because the AstraZeneca vaccine was the one that was ruled out there. But look at the UK. I want to maybe end on a happier note. And this is what I think we can expect in the UK when they had a roaring B117 wave happening in winter. They quickly and rapidly rolled out their vaccination program with mostly AstraZeneca, but also Pfizer, and they were able to get their incident cases right down. And they in fact opened on April 12th, and their numbers have gone up a little bit, but they're staying steady. So this is what we're hoping is going to happen here. And we're getting there. So in Canada, as of last night, 36.112% of people are vaccinated. And apparently the magic number is 60%. That's what was seen in Israel. When you reach 60% of the individuals who've received their first vaccine, we really see a difference in the incident rates going down. And that's the goal for, I think actually all of Canada. Some provinces even have the goal of 70% by the end of May. Okay, so in summary, my personal feeling is that the COVID-19 viral vector vaccines are very effective, and 2 of them are approved in Canada. I think they're an important part of our vaccine program. We now understand the vaccine-induced thrombosis and thrombocytopenia risk and mechanism. So if someone's had the vaccine, either of these vaccines, and develops the known symptoms, they should go to hospital right away, and we know how to treat them. The UK studies show that vaccination is reducing cases, and therefore it's critical to get vaccinated. We really can't get out of this without herd immunity, which will be primarily by vaccination or people acquiring COVID. The new variants are of concern and are a problem, and even more of a reason to get vaccinated. But please continue to wear masks, hand wash, and social distance. Please continue to not gather and be vigilant, and not go to work if you get sick. So thank you so much, and here are my references.